Hi students, this is Dr. Tatum. Today we're going to talk about Chapter 19, which is Assessment of the High-Risk Pregnancy. So if you'd like to take out your PowerPoint slides and follow along, I will start on slide 2. I also think it will be important to have your textbook available just because I will be pointing out some page numbers in your chapter that are going to be great resources for you to utilize as you start to learn this material. So before we begin, I'd like to just define what a high-risk pregnancy is. A high-risk pregnancy is one in which the life or health of the mother or fetus is jeopardized by a disorder. And so there are lots of contributing factors, things like advanced maternal age, greater than 35, if she smokes, if she drinks alcohol, or if she does any illegal drugs, that also increases the risk related to pregnancy. And then also maternal health conditions like hypertension, obesity, diabetes, thyroid disorders, cardiac problems, asthma. There are lots of different medical conditions that can also put that pregnancy in that higher risk category. It's important to find out if she's had past pregnancies and if she's had any complications with those pregnancies. So things like hypertension, gestational hypertension, or preeclampsia also are going to make her current pregnancy more higher risk. So with that, I'd like to move on to slide 2, and let's talk about Susan. So Susan is a 17-year-old G2P0, so gravida 2, para 0, presenting to the clinic for her first prenatal visit. Exam results show that she is 26 weeks pregnant. She lives with her boyfriend. She admits to drinking 3 to 4 cans of Mountain Dew daily. She is a social smoker, and she denies any over-the-counter or prescription medication use. Her vital signs include a temperature of 97 degrees, a pulse of 84, respirations of 18, a blood pressure of 108/76, and a BMI value of 17. So what risk factors are present in Susan's current pregnancy? And so I'm going to give you just a few seconds to review that information, and we'll talk about it together. So as I'm looking at this information, I see that she's 26 weeks pregnant, and this is her first prenatal visit. So already that tells me that she is late to prenatal care, and that increases her risk factors for this pregnancy. Also, she drinks 3 to 4 cans of Mountain Dew daily, and that increases her caffeine consumption, which could predispose her to a miscarriage. She is a social smoker, and we know that smoking can contribute to low birth weight babies or intrauterine growth restriction. And also she has a BMI value of 17, which is on the lower end. And so I'd be more concerned about her general dietary practices. She's underweight. Will she have any nutritional deficiencies related to this pregnancy? What other additional information do we need to obtain from Susan? So as I look at her history, I would want to know about her first pregnancy. So she's a gravida 2. What happened with her first pregnancy? I would like her to tell me more about her current pregnancy. What complaints does she have? Does she have any morning sickness? Is she fatigued all the time? Does she have any backaches or pressure? Um, what out of the ordinary is present with this pregnancy that could cause some concern? I would want to know about her significant health history and also her family history. And then I would also want to know if she had any past surgeries and what is her support system like? You know, she is 17 and she lives with her boyfriend. So that might predispose her to just financial insecurity and might make her feel more that she's alone in this pregnancy as well. So I'd like to find out more information about those factors. All right, let's move on and we'll talk about biophysical risks. So biophysical risks include genetic disorders, medical and obstetric related illnesses, nutritional and general health. So with genetic disorders, basically we want to know if there's any genetic factors that can interfere with the normal growth and development of the fetus. So things like defective genes, inherited disorders, and chromosomal abnormalities would fall into that category. Medical and obstetric related illnesses would be any complications with her current pregnancy or past pregnancies. Also, pregnancy-related illnesses like preeclampsia and also pregnancy losses fall into this category. Nutritional and general health. So just finding out if she has adequate nutrition. Does she have any nutritional deficiencies present? Does she use tobacco, alcohol, or drugs? Or does she have any inadequate or excessive weight gain related to this current pregnancy? And then psychosocial risk factors would be more of maternal behaviors and lifestyles. So again, smoking, drug use, and alcohol use all fall into this category as well. But also here would be maybe her caffeine intake. So greater than 200 milligrams of caffeine per day increases her risk for a miscarriage. Does she suffer from any emotional distress or depression, anxiety? Does she suffer from any abuse? We know that intimate partner violence and domestic abuse increases with pregnancy, so that would be something to really ask her about. And then also any hazards in her workplace. So is she exposed to any chemicals or pollutants in her workplace that could interfere and place her pregnancy at risk? We'll move on and we'll talk about slide 4. Sociodemographic risk factors would be low income, marital status, and ethnicity. So with low income, oftentimes women who have low income will not have enough prenatal care on board. So they might come later into the clinic, maybe in her 3rd trimester, she's finally seen. But lack of prenatal care is something that we are concerned about. Also, inadequate nutrition, just because they're not they're not apt to actually buy healthy foods. And then also low income status can also increase medical complications related to pregnancy. With marital status, oftentimes unmarried women have higher mortality and morbidity rates, and there's also a higher risk for preeclampsia, which is interesting. And then ethnicity, race in general. So non-Caucasian women are more likely to die from pregnancy-related causes. So specifically right now, African American women are at high risk for pregnancy complications. Their pregnancies are considered high risk, a lot of times due to underlying medical reasons, but they are more likely to die from pregnancy-related complications than white Caucasian women are. And then environmental risk factors would be any hazards in the workplace. So chemicals, radiation, and pollutants. Chemicals like pesticides, lead, mercury, radiation, and also industrial pollutants all increase the risk for a miscarriage. Let's move on and talk about antepartum testing. So the role of antepartum testing is to detect any potential fetal compromise. So what we want to do is detect this before really harm does occur to the developing fetus. So in most cases, we worry about a disruption in fetal oxygenation that could lead to asphyxia over time. Most cases begin at 32 to 34 weeks gestation and continue until birth. So some of the things that we use to monitor the fetus in greater detail would be a non-stress test, a contraction stress test, and a biophysical profile. And we'll talk more about all 3 of these monitoring and antepartum testing as we progress in this lecture. I do want to point out on page 563 in your text, box 19-3 talks about maternal and fetal indications for antepartum testing. And a lot of these relate back to all the medical conditions that we talked about. So things like diabetes, chronic hypertension, preeclampsia, fetal growth restriction, multiple gestation, oligohydramnios, which is low amniotic fluid levels, a preterm premature rupture of membranes, and post-state or term gestation all can be causes for concern, and that would lead us to do more antepartum testing on these individuals. So let's move on and we'll talk about slide 6 here, and that talks about daily fetal movement counts, also known as DFMC. You're going to see that in your textbook. So KIC counts are super important. Basically, this allows us to assess the fetal activity But what the mother does is that she assesses this at home. It's non-invasive, it's inexpensive, and it's just simple for her to do. So it does not interfere with her normal routine in her home or daily structure. But what she needs to do is she counts fetal activity 2 to 3 times a day for 60 minutes. And what happens is if she feels fewer than 3 kicks per hour, then she really needs to call the doctor for further testing. If the baby's not moving around more than that, then we get a little more concerned and we want to investigate it further with maybe a non-stress test or a contraction stress test or maybe even a biophysical profile, like I mentioned in that slide before. Fetal movement not present during the sleep cycle is something that we need to educate her about. If the baby is sleeping, then the baby's not going to be moving around much. And so just point that out to her. And then the fetal alarm signal goes off if she feels no movement within 12 hours. So that causes a lot of concern. She needs to come in and be evaluated, but also tell her that she might feel decreased movement if she's taking an antidepressant or if she smokes or drinks any alcohol as well. All right, let's move on and we'll talk about ultrasonography. So this uses sound waves to produce a picture. So this is safe and it's one of the most important surveillance techniques that we use today to detect any complications. So what it does is it provides critical information about fetal activity, the gestational age of the fetus, normal versus abnormal fetal growth patterns. It allows us to visualize what's going on in utero, especially if we have to do any more invasive tests like an amniocentesis. It allows us to see fetal and placental anatomy, and it's used to assess fetal well-being in general. So usually women that are at 20 weeks gestation will have an ultrasound. And that's when they say that baby is large enough that they can really assess and do a detailed ultrasound of all the anatomy of the fetus, which is really fun for mom and dad. They can detect the sex of the baby if they want to find out as well. So basically, usually the abdominal ultrasound is more useful after that first trimester, but she does need to have a full bladder just because that's going to place that uterus more upward for better visualization. But remember that right after that first trimester, the uterus becomes an abdominal organ, and that's why we use that that's why we use an abdominal ultrasound after that first trimester pregnancy. So what happens is transmission gel is placed on the abdomen, and that is used to enhance transmission and reception of those sound waves to create a better picture of the baby. A, a transvaginal ultrasound is used in that first trimester, and we use that more to really see pelvic anatomy in greater detail. With this, the bladder does not have to be full, but we use a transvaginal ultrasound to detect an ectopic pregnancy, so maybe a pregnancy that has occurred in the fallopian tube rather than the uterus. We monitor the embryo, we can help identify any abnormalities, and we also can use it to establish gestational age. So on page 565 in your textbook, this page shows some major uses for ultrasound during the different trimesters. So in the first trimester, it helps confirm pregnancy. We can detect the viability of the fetus and detect if there is a multiple gestation pregnancy. In the second trimester, we use it to establish and confirm due dates. Again, assess viability of the baby. We also assess for polyhydramnios, which is excess amniotic fluid, or oligohydramnios, which is low amniotic fluid. We also can see the growth of the baby. And then that third trimester, we use it to, again, confirm gestational age of the baby. We also use it to see how large the baby is. We can detect any macrosomia that could be present. We can assess fetal position and also the position of the placenta. So on this next slide, again, you can see all the different indications for use like I've just gone through. And then we also use ultrasonography to assess just a blood flow analysis. We can see basically the blood flow or resistance in the baby's circulation. And so I'm going to stop here because I'm going to be cut off here in a minute, and I'll start here again soon.